one and all, welcome to our virtual coffee break. Unfortunately, due to circumstances, it's a little bit different than usual. We would like to invite you for real coffee at the Technoclone booth, but we do it now differently. Today's subject is laboratory monitoring of Haemophilia Therapies, and here with me is my esteemed colleague, Dr. Gary Moore, which holds the position of Director of Clinical Diagnostic Research. Welcome, Gary. To start, how has haemophilia therapy changed over the years?
Well, quite a lot. The first ever whole blood transfusion for haemophilia took place in 1840. And it wasn't until the early 1920s that plasma replacement therapy was used. So from sort of like the 50s to 1960s, fresh frozen plasma was the main treatment, but it did require large volumes to be transfused. So come the mid-1960s, with the availability of cryoprecipitate, that did at least allow smaller volumes for transfusion for haemophilia A. Revolutionary change in 1970 with the availability of freeze-dried human plasma-derived concentrates that the patients could undertake home-based prophylaxis. But as we all know, sadly, in the 70s and early 80s, hepatitis and HIV transmission occurred. And it wasn't until 1987 that heat-treated factor VIII was available to reduce the infection risk. A couple of years later, 1989, recombinant factor VIII was available, which represented no infection risk. And it wasn't actually, in fact, until 97 that recombinant factor IX was available for haemophilia B. They were the mainstays for a long time until the arrival of the extended half-life recombinant products in 2014. And more recently, we're seeing the entry of non-replacement therapies into the treatment armory.
And have these improvements and modifications generated challenges for the laboratory when monitoring treatment?
Not initially. For decades, we only needed standard one-stage clotting assays with plasma calibrators for the plasma-derived concentrates, ideally traceable to the WHO standards when they were available. Then, as now, you needed to do parallel line bioassays to ensure accuracy and identify interferences. So for decades, in the hemostasis lab, you needed one factor VIII assay and one factor IX assay, and that was it. It was nice and simple.
Right. And did the recombinant products require any assay modifications?
Most of the recombinant factor VIIIs we can monitor with standard one-stage assays with plasma calibrators. The one exception there being the B domain deleted refracto. If you're going to use a one-stage assay, you do need a product-specific calibrator. So some labs, like the one I used to work in, you might just choose to use chromogenic assay for all of them, for all the plasma-derived or all the recombinants. The recombinant IXs equally can be monitored with a one-stage assay and a plasma calibrator. A few APTT reagents might not work so well, and the chromogenic IX assays are a bit inconsistent for the recombinant IXs.
Yeah, right. And what solutions does Technoclone have for plasma-derived and recombinant factor VIII and recombinant factor IX?
Well, we have fully automated parallel line bioassays for both factor VIII and factor IX. Unlike a lot of manufacturers, we have native deficient plasmas as well as immunodepleted if they're your preference. Plasma calibrators are all traceable to WHO standards. All can be done fully automated on the Sevron analyzers. And if you did need to use, for instance, the Refacto product-specific calibrator, the Sevrons are an open system, and you can use separate calibrators as well.
Right. And how have the extended half-life products affected laboratory practice?
The only answer I can give to that is massively. The APTT reagents on the market, they vary so much that there isn't one reagent that you can use to measure every single product. Fortunately for the factor VIII extended half-life products, the chromogenic assays work for most, in fact, probably all of them. But almost no APTT reagent will recover each of the factor IX extended half-life products. And even the chromogenic IX assays are variable. So you almost certainly need more than one reagent for the factor IXs.
Yeah. And what solutions does Technoclone offer for extended half-life products?
Well, For the factor VIII extended half-life, the chromogenic assay is the obvious solution. You can use it for every single one. Unfortunately, there aren't any data out there yet on our routine APTT reagent Daptin, but as I said, the Severon is an open system, so if you needed an additional APTT, you can easily use them on the Severon, so that's not really a problem.
Right. And can the hemostasis laboratory monitor non-replacement therapies?
An interesting, very good question. Of course, the only one in current clinical use is emicizumab, which is a bispecific antibody that mimics activated factor VIII. But unlike factor VIII, it doesn't require activating. It works straight away. So if you can't use APTTs, because all the clotting times are short, all the factor VIIIs are overestimated. So the only way to measure endogenous factor VIII in a patient receiving emicizumab is with a chromogenic assay. But even more than that, the chromogenic assay has to have bovine activated factor IX and bovine factor X in order to measure either endogenous factor VIII or, in fact, inhibitors to endogenous factor VIII or replacement therapies. Interestingly, the Technoclone chromogenic factor VIII assay is a bit of a hybrid because the activated factor IX is human and it's only the bovine factor 10 or the 10 that is bovine. But there are some studies that were shown at last year's STH to show that that assay is still suitable for measuring factor VIII and inhibitors in patients who are on emicizumab. But if you want to actually measure a drug level, an emicizumab level, you do need specific calibrators. They're only available at the moment from the R² company, and you can use them with any APTT reagent. So you could use Daptin to measure emicizumab levels should you need to.
Yes. Very interesting. What about the antithrombin RNA interference drug and anti-TFPI currently in trials?
Well, they present interesting challenges because you can't measure residual hepatocyte polynucleotide levels. So our surrogate marker is perhaps obviously to measure levels of antithrombin because the RNA is interference is reducing levels of antithrombin. But the question is, what does an isolated antithrombin level tell you about the actual rebalancing of the coagulation that you have achieved? So it only gives you minimal information. For the anti-TFPI, there's no assay to actually measure the anti-TFPI drug itself. Or in fact, you can't measure endothelial TFPI. Most of your TFPI is attached to the endothelium. You can measure plasma TFPI, but it's not telling you everything you need to know. So probably, and what is recommended, probably the best assay is thrombin generation.
Yes. So what are the solutions that Technoclone can offer for this?
Well, I'm not going to tell you everything. What I want you to do is visit our product theatre because we've got some new data relating to phytocyran that we'll be showing you in the product theatre. But it is on thrombin generation. But the important thing here, whichever way you choose to monitor your haemophilia therapies, and of course you're going to choose at least 2, if not 3, the Severon can perform one-stage assays, chromogenic assays, and thrombin generation all together on one platform simultaneously, should you need them.
Right, yes, that's very exciting news. And for all the viewers that are interested in our product theater, on Tuesday, 14th of July, 1:15 American Standard East Time, we have our product theater. I would like to thank you all for watching and take care. Bye-bye. Thank you.